All right, guys. Did you all join the new link? All right. Sorry, guys. Thank you for keeping up with the little bit of patience. The team was also quick in creating whatever they could. Okay. Let's continue. Just quick thumbs up if you're able to hear me, if you're able to see me. Quick feedback. Can we start? Can we start? Can we start? All right. Great. Chalo. So we'll talk about nephrolithiasis, that are going to be your stones basically. So when you talk about nephrolithiasis, remember 90% of them are radio opaque. 90% of them are radio opaque and 10% of them are radio opposite is for gallstone. Okay. Hi Mushtaq, good evening. So when we talk about the nephrolithiasis, we'll be talking about four common ones: calcium oxalate stones, the phosphate, uric acid, and cysteine stones. Remember, the overall most common type of renal stones are going to be calcium oxalate. Phosphate is most radio opaque stone. Uric acid is the most common radiolucent stone, and cysteine is considered to be as the hardest renal stone. It is considered to be, it is going to be your hardest stone. Okay. What is the characteristic feature that you're going to see? Now, the calcium, when you look at the cause per se, it is because of anything that results in excessive amount of calcium excretion. So it could be hypercalciuria, hyperoxaluria, and all that. So here, hypercalciuria. Phosphate is because of protease infection. Uric acid stones are because of excessive amount of uric acid production, example like gout. And cysteine stones is because of cystinuria. Now, when you say the characteristic feature, calcium oxalate stones, they are round to oval in shape. They are round to oval in shape. They have sharp projections. They have sharp projections. They are dirty white in color. They are dirty white in color. They are dirty white in color. Phosphate stones is what we call it as the triple stone because it consists of calcium, magnesium, phosphate crystals. Along with triple stone, it is also called as struvite stone. It is also called as a staghorn calculi. Also called as a staghorn calculi. Now, uric acid stones, they are formed in the acidic urine. So here I don't need to treat the stone. All that you have to do is to alkaline the urine. So alkalization of urine is done with the help of acetazolamide. Cysteine stones, when you talk about characteristic stone features, they are black in color and they have hard stones. Now, they also consist of sulfur. So, cysteine stones are black in color, they are hard stones, and more importantly, they consist of sulfur. Calcium oxalate stones are radio opaque, phosphate is radio opaque, uric acid is radiolucent. Because cysteine consists of sulfur, it is going to be your radio opaque one. Now, the crystals are important for calcium oxalate stones. Remember, you get envelope crystals. This is in phosphate stones, it is coffin lid. Uric acid stones, it is multi-faced. Cysteine, it is going to be hexagon. The hexagon is also called as benzene shaped crystals. The urine microscopy, they are called as benzene shaped crystals, right? So in terms of investigation, ultrasound becomes the first, I would say, X-ray KUB becomes the first investigation because all that renal stones that you have are radio opaque, most of the 90%. Ultrasound is basically done to look for the size of the stone. It is to look for the location of the stone and to evaluate for hydronephrosis. Now, CT urography, which is the NCCT of the kidney, is the investigation of choice. And this was this year's exam question, right? DMSA stands for dimercaptosuccinic acid. Now, this dimercaptosuccinic acid is a radionuclide scan which is done to look for the morphology of the kidney, to look for renal scarring, and for the assessment of renal anatomy, you will use DMSA scan. DTPA stands for diethyl triamine, pentacetic acid. It is diethyl triamine pentacetic acid, right? Now, this is the investigation of choice for renal perfusion. This is the investigation of choice for renal perfusion. MAG3 is your mercapto. It is mercapto acetyl triglycine. It is mercapto acetyl triglycine. This is gold standard. This is gold standard for renal perfusion. For renal perfusion. All the 3 points that I've told you has been a previous exam question. When will you use a DMSA? When will you use a DTPA? When will you use a MAG3? Okay? When will you use a MAG3? Guys, if you have any questions, any doubts, keep posting it down. You don't need to say there's a doubt. If there's a doubt, type it. I will analyze it and I'll give you the answer then and there itself. Okay? Now, the management depends on the size of the stone. Less than 5 millimeters, it is going to be conservative management. 6 to 15, it is going to be ESWL, extracorporeal shock wave lithotripsy. More than 15, it is going to be PCNL. Staghorn, it is going to be your sandwich technique, which is going to be your ESWL with PCNL. It is ESWL with PCNL to be done. Okay? So this is mota that you have to know in terms of management. Genitourinary tuberculosis is important. What are the findings that you will see in kidney? In the kidney, you have the cement kidney. The cement kidney will become putty kidney. Eventually, this putty kidney will convert into autonephrectomy. It will convert into autonephrectomy. For bladder, in the ureter, you will see there's presence of golf hole ureter and then converting into thimble bladder. Then converting into thimble bladder. For prostate, it will become hard indurated prostate. It will become a hard indurated prostate. For vas, it is going to become a beaded vas deficit. For scrotum, it will present to you with multiple discharging sinus. For multiple discharging scrotal sinus. Right? Kancham, we have Bailey series will done once our exam series are done. अभी हम exam series कर रहे हैं अपना NEET PG का, INSCT का, FMG का. Once we're done with this, we'll restart our Bailey series. Like Bailey is our love. We are going to do it for sure. But अभी थोड़ा exam season चल रहा है तो थोड़ा exam के लिए important चीजें we're trying to do it right now. ठीक है? So these are all the important components of genitourinary tuberculosis. It's a genitourinary tuberculosis. ठीक है? Now, again, coming to another very important topic that is going to be, 1 second guys. Right, we'll be talking about the benign prostatic hyperplasia. Just give me 1 second guys. Alright, so when you talk about BPH, that is a benign prostatic hyperplasia, a couple of important things that are important. Number 1 is going to be pathophysiology. One second guys. Right. So when you talk about the pathophysiology of BPH, it is an age-related phenomena. This is what you need to know. As age increases, the testosterone in the body is going to reduce. Now, how does it reduce? Is normally the testosterone that is present, that is going to get converted into dihydroxy testosterone. Now, this is done with the help of enzyme that is 5-alpha reductase. Now, what is important about this is this dihydroxy testosterone is the most potent stimulator. This happens to be the most potent stimulator of prostate gland. Now, as the age increases, more and more amount of 5-alpha reductase enzyme will be formed. So, more and more amount of dihydroxy testosterone will be produced. Hence, because of that, there will be excessive proliferation of the prostatic gland causing the urethral compression. So, this is the whole objective that you see in BPH. So, if I say the single most important culprit is going to be a dihydroxy testosterone with respect to 5-alpha reductase enzyme. So, our treatment is going to be revolving around this. Now, any patient of BPH will have two set of symptoms. This is your exam question. Which of the following is voiding? Which of the following is storage? Voiding में hesitancy है, poor flow है, intermittent stream है, post menstrual dribbling है, poor sense of evacuation है, episode of near retention. Storage में क्या है? There is increase in frequency, there is nocturia, there is urgency, urge incontinence and nocturnal incontinence. तो इतना याद रख लेना, अगर पेशेंट को सुसु करते वक्त कोई सिम्टम है वो आपका वॉइडिंग सिम्टम होगा, लेकिन पेशेंट को सोते सोते कोई सिम्टम है वो आपका स्टोरेज सिम्टम हो जाएगा. सो यू नीड टू बी इन दैट पर्टिकुलर कॉन्टेक्स्ट. When we talk about complication, अगर आपको सिस्टोस्कोपी में ये मिला where you have all these bands, this is what we call it as bladder trabeculation. Now, bladder trabeculation is basically a telltale sign of chronic pressure within the bladder. Okay? And this is presence of bladder diverticula. Both of them occurs when there is increased pressure inside the bladder. Why will the pressure increase inside the bladder? Very simple concept, because BPH is compressing. So when the prostate gland enlarges, so this is the bladder that you have, and this is the prostate gland that you have, and this is the urethra that we're talking about. Okay? So if the prostate gland enlarges, it will compress the prostatic urethra. If it compresses the prostatic urethra, the bladder will not be able to empty the urine properly. Hence, you will see the bladder will start to hypertrophize, and this is what we call it as detrusor instability, and that is trying to gain by contracting the bladder muscle. Okay? So this is the objective that you have in this particular context. Okay? So, now, in terms of investigation for benign prostatic hyperplasia, digital rectal examination should be done. You would see presence of enlarged prostate gland. There will be presence of an enlarged prostate gland. You can do an ultrasound to assess the size of the prostate. You can do for the assessment size of the prostate. Investigation of choice is going to be uroflowmetry. I've been always telling in my class, the problem in BPH is not because of the gland size, it is because of detrusor instability, and that can be analyzed on the basis of uroflowmetry. If it is more than 15 ml per second, it is normal. If it is going to be between 10 to 15 ml per second, if it is between 10 to 15 ml per second, it is called as equivocal, possibility of an obstruction. But if it is less than 10 ml per second, less than 10 ml per second indicates obstruction, and that indicates require any form of intervention. Okay? The prostate specific antigen should be done. Remember, the normal PSA should be less than 4 nanograms per deciliter. Okay? Now, when you look at the elevated PSA, or PSA of more than 20 nanograms per deciliter indicates prostate cancer. It indicates prostate cancer. In which condition you have elevated PSA? Elevated PSA, that is between 5 to 19 nanograms per deciliter. Now, this 5 to 19 nanograms per deciliter, this 5 to 19 nanograms per deciliter, you will see in the context of following prominence. You have A, B, C, and D. A stands for acute bacterial prostatitis. You have acute bacterial prostatitis. B secondary to BPH. C is going to be recent catheterization. And if the patient has underwent a recent digital rectal examination, in all these there will be elevated PSX. ठीक है बेटा सर्जरी की पीडीएफ सून आफ्टर द क्लास आपके सामने लाइव में पीडीएफ भेजूंगा उसके बाद हम एंड करेंगे ठीक है सो डोंट वरी अबाउट इट नाउ व्हेन यू टॉक अबाउट द मैनेजमेंट the first line management is going to be medical management and the drug of choice is alpha 1A blocker that is going to be your tamsulosin. Okay. Now, if the patient does not respond to medical management, the surgery of choice for BPH is going to be TURP, that is a transurethral resection of prostate gland. Remember, they'll ask you the irrigating fluid of choice. The irrigation or irrigating fluid of choice. The irrigating fluid of choice is going to be 1.5% glycine. It is 1.5% glycine. Okay. So this is the basic image before and after, just for the sake of understanding. लेकिन अगर आपसे पूछेगा when you should not do TURP, what is the contraindication of TURP? If a patient is having a known hip disorder, because I cannot put the patient in lithotomy position. If patient has any bleeding disorders, hip disorder, bleeding disorder, and if the size is more than 100 cc or time taken could be more than 90 minutes, this is a relative contraindication that you have. Now, whenever you have contraindication for TURP, obviously you'll go with open surgery. Now, just for the sake of understanding, the open surgeries that we have phrase surgery. Phrase surgery is going to be transvesical. Then you have Millen's surgery. Millen's is going to be retropubic. Then you have Young's surgery. It is your perineal route of approach. So phrase is transvesical. It is your transvesical. Millen's is retropubic and Young's is going to be the perineal route of approach. It is your perineal route of approach. Okay? The newer one that you have HOLIP, that is your holmium laser prostatectomy. It is holmium laser prostatectomy. So it's a laser induced prostatectomy, which is the latest one. Okay? Palash, it's a good suggestion. Thank you so much. I'll consider that. Okay. So, next, going on to the next topic, we have congenital disorders of testes. I'll do a quick recap between an undescended testes and the ectopic testes. Remember, in an undescended testes or ectopic testes में फर्क क्या है? Undescended testes, the testis is present in normal embryonic path. In ectopic, it is away from normal path. In both the conditions, you will not see the testis in scrotum. So how do you differentiate? Undescended में normal path में मिलेगा, ectopic में वो आपको normal path में नहीं मिलेगा. So undescended testis का most common site जो है, that is going to be within the inguinal canal. Ectopic, it is going to be superficial inguinal pouch. It is a superficial inguinal pouch. The status of the testes in undescended is going to be poorly developed, whereas ectopic it remains normal. Secondary sexual characters unilateral, it will be present. In a bilateral undescended testis, it will be lost. Ectopic remains normal. Spermatogenesis is absent in undescended, it is normal here. Scrotum is poorly developed, whereas it is normal in your ectopic testes. When talk about the investigation for both of them, you have to do a clinical examination. Okay? Now, ectopic is easy to manage. The management of undescended testes is important, right? So it's a protocol based approach that you should know. When a patient comes to you with an undescended testes, the first thing you will ask or see whether it is a unilateral or a bilateral undescended testes. If it is unilateral, I will see whether it is palpable or whether it is non-palpable. Whether the testes is palpable or whether the testes is non-palpable. If the testis is palpable, there is no rocket science in it. Do orchidopexy. If the testis is not palpable, to localize it, you will do a diagnostic laparoscopy. You will do a diagnostic laparoscopy. In the diagnostic laparoscopy, you will see abdominal testis or blind vessel. You will see presence of an abdominal testis, or you can have a blind ending vessel. If it is an abdominal testis, you have to go and perform orchidopexy. Blind ending testis means there is only one testis. The diagnosis here will be monoorchia. Now, if it's a bilateral undescended testes, the first thing I should know whether the testes exist is the baby male or female. For that, I will give injections of beta HCG. After giving injections of beta HCG, I will look for the response. Is there any response present or not, right? So when I say there is presence of response or absence of response, presence indicates that there is increase in FSH, increase in LH and GnRH. Okay. When there is no response, if it has no response, then it will be called as anorchia. And for this, now you have to look for sex determination. Okay. If there's presence of response, that means there's presence of testes. Then I have to take it for diagnostic laparoscopy. You have to take it for diagnostic laparoscopy. So this is the management of your undescended testes. Sorted? Clear? Okay. So this is with respect to your undescended testes management. Now, what are the important images that you need to know? The first one, you cannot miss this. It's a spotter. What is the diagnosis? It is going to be your Fournier's gangrene. I've already given you the diagnosis also. This is your Fournier's gangrene. When I say a Fournier's gangrene, what does basically the Fournier's gangrene means? It is the necrotizing fasciitis of the perineal region. It is the necrotizing fasciitis of the perineal region. Is the necrotizing fasciitis of perineal region. It is a combination of both aerobic as well as anaerobic organism. It is usually seen in patients with diabetes or immunocompromised. Diabetes or immunocompromised. It will have a foul smell with rice watery discharge. Rice watery discharge. Testes are usually spared. Their testes are usually spared. The management here is going to be debridement with antibiotics. With antibiotics, right? Which is better answer for hemorrhoid surgery? Millimorgan surgery or stapler hemorrhoidopexy? But if they ask you what is the surgery of choice, it is going to be your hemorrhoidectomy. But if they ask you which is the latest modality, then it is stapler hemorrhoidopexy. Okay? Right. Coming back to the radiological images that you have, the first image that you can see, this is of horseshoe kidney. The finding that you are able to see here is what we call it as the flower vase appearance. It is a flower vase appearance. Now, in the horseshoe kidney, two things that you should know. Number one, the level of the isthmus and the vessel over the isthmus. Now, it is usually seen between L3 and L4 is the isthmus, and it is the inferior mesenteric artery that prevents the ascent. Okay. So, when I talk about the L3 and L4, this is the site of the isthmus of the horseshoe kidney. Inferior mesenteric artery prevents, it prevents the ascent. It basically prevents the ascent. Okay. Now, the image number 2 that you are able to see here, this is your Staghorn calculi. We have already dealt with the stone, so nothing more about it. It is your Staghorn calculi. Similarly, you can see another one where you have more rounded off edges. You can see this is more round, this is more sharp. Rounded ones are your putty kidney that you see in tuberculosis. We have already covered that as well, right? The next one that you have, this is fish hook ureter. Now, the fish hook ureter, it is called as retrocaval IVC. It is basically seen in retrocaval ureter. That means the ureter is going around the inferior vena cava. So this is where the inferior vena cava is present. You can see the ureter has gone behind it and then it has come anteriorly. This is your fissure. This is what we call it as soap bubble sign. This is what we call it as the soap bubble sign of hydronephrosis. This is the soap bubble sign of the hydronephrosis. This is your spider leg appearance. This is your spider leg appearance of polycystic kidney disease. The polycystic kidney disease. It's a polycystic kidney disease. So remember, PKDs are usually bilateral. The treatment of choice for PKD is going to be renal transplant. It is going to be renal transplant. Okay. So multiple other things can be there, but this is the baseline data that you should, right? So this is all in all that you should know with respect to our today's revision series. I know it was a little bit lengthy, but we tried to cover almost every single thing that there it exists. Okay. So, beta hernia we didn't have. I'll do a quick recap on hernia. Wait. So let's take it down from here only. Just give me 1 second. Where is our hernia? चला गया hernia. Just give me 1 second, guys. Okay. So hernia में quick recap कर लेते हैं. Right. So usually we'll be talking about the inguinal hernias. In the inguinal hernia, we'll be talking about direct and indirect inguinal hernia. This is a small diagram that we usually use. This is the orientation that you need to keep. So direct और indirect inguinal hernia में जो difference usually पूछा जाता है, entry point कहाँ पे है? For an indirect inguinal hernia, this is your deep inguinal ring, this is your superficial inguinal ring. So entry for indirect is going to be from deep ring, exit is going to be from the superficial ring. Direct के लिए entry is going to be from the Hasselbalch's triangle, exit is going to be from your superficial inguinal ring. ठीक है? Both when you look at the sac of indirect, it is formed by the peritoneum, whereas the sac of direct will be formed by fascia transversalis. ठीक है? Now, when you look at the content, it is going to be same for both of them. Relationship of the cord and the sac is important. So, when you talk about in indirect inguinal hernia, the sac lies lateral to the cord or the cord lies medial to the sac. In the same context, when you talk about direct inguinal hernia, you see the sac lies medial to the cord or the cord lies lateral to the sac. Okay? We need to look at the neck. Neck is the entry point with respect to inferior epigastric artery. Neck lies lateral. If you say this is the inferior epigastric artery, the entry is lateral in indirect, whereas entry is medial in going to be your direct inguinal hernia, direct inguinal hernia. Okay. Now, all the other things are okay, fine, not a problem. They'll ask you about the triangles that you have. The triangle of doom, the triangle of pain, and the crown of death. These are the three important things that you will see. What are the boundaries of the triangle of doom? When you look at the triangle of doom, you will see it is the deep inguinal ring, which is going to be the apex. The medial is going to be vas deferens. The lateral is going to be your gonadal vessels. And the peritoneal reflection, your external iliac artery, external iliac vein is the content of your triangle of doom. Coming back to triangle of pain, just lateral to it, you will see triangle of pain. You have medially the gonadal vessels, the iliopubic tract, that is laterally, and inferiorly by peritoneum. These are the nerves which are present. The most common nerve injury in your laparoscopic hernia repair, it is going to be lateral cutaneous nerve of thigh. The most common nerve injury in open inguinal hernia repair, it is going to be ilioinguinal nerve. The most common nerve gets trapped in the mesh in an open inguinal hernia repair is going to be iliohypogastric nerve. Corona mortis is the crown of death. It is nothing but aberrant obturator artery connecting between your inferior epigastric artery and the obturator artery. It's an abnormal connection between inferior epigastric artery and the obturator artery. Then they'll ask about the mesh. Remember, the most commonly used mesh is going to be proline. What is the ideal characteristic? It should be non-absorbable. It should be lightweight, less than 40 milligrams per 40 grams per meter square. It should have large pore, and then it should be hydrophobic. It should repel water. Okay. These are the two images, proline mesh and the composite mesh. That is important. Now, all these are preferably not that important. If you have looked at the table, this is the comparator table that you would need to know with respect to umbilical hernia, spigelian and lumbar hernia. Remember, when you talk about umbilical, the defect is usually 2 to 4 centimeters. Spigelian is very small. That is going to be with respect to less than 2 centimeters. Lumbars are going to be bigger one. See, the lumbar hernia, two triangles. The triangle of Greenfeld, which is called as superior lumbar triangle. The triangle of Petit, which is called as an inferior lumbar triangle. Both of them are important. I'm just going to put the document. Just go and revise the components here. For all these, remember, IPOM, that's intraperitoneal only mesh repair, is the treatment of choice. For lumbar hernia, it is Daoud-Ponkar repair. So what is this mesh placements? This is an exam question which was asked recently also. What is an onlay repair? Onlay ka matlab hota one layer below. So here when you look at the layers that we have described it, this is how we describe it. The outermost skin, then the subcutaneous fat, external oblique muscle, internal oblique, transverse abdominis, fascia, transversalis and peritoneum. If you put under the subcutaneous fat, it is called as onlay. If you're going to present between two rectus abdominis, this is what we call as inlay. If you put it under the rectus abdominis muscle, it is called as sublay. If you put it between the rectus and the posterior rectus sheath, it is called as retrorectus. And if you place it just above the peritoneum, it is called as IPOM, intraperitoneal onlay mesh repair. Okay? So these are with respect to mesh placements. Then you'll have these two images which are very commonly asked. What is omphalocele? What is gastroencephalitis? Omphalocele will have a membrane. Gastroencephalitis are exposed. Omphalocele is an umbilical defect. Gastroencephalitis is usually on the right side. Omphalocele associated with Beckwith-Viehmann syndrome and cardiac anomalies, whereas gastroencephalitis is only with intestinal atresia. Okay? Mesh between the rectus abdominis muscle and the posterior rectus sheath is going to be retrorectus. That is what I'm trying to tell you. Retrorectus is going to be between the rectus abdominis muscle and the posterior rectus sheath. इसको आप retrorectus बोलोगे. Clear है? ठीक है? So what I'll do is I will take all the important slides from here. And then I'll add up there. So which was important? सबसे पहले difference is important, triangles are important, mesh is important, comparison between these are important, this is important, this is important. Okay. Okay. So copy कर लिया. Okay. We'll go back to our original document जो हम आज पढ़ा रहे थे. Okay. इस पे आपने paste कर दो. ठीक है. So now you have this also. Yeah. So this concludes your entire discussion on general surgery. That is important. We try to cover all the topics in the most elaborate length that is possible. I try to do a justification as much as possible. Okay. Okay. We'll do NEET PG beta Palash. It's a good suggestion. I'll consider that as well. Beta, if you have नॉट फिनिश्ड एनीथिंग। देखो अभी बैठ के पूरा नया नहीं पढ़ना है, जितना मैंने आज पढ़ाया है फॉर आवर एग्जाम इट इज एब्सोल्युटली इनफ इफ यू आर एबल टू रिवाइज द एंटायर टॉपिक्स दैट वी हैव डिस्कस्ड टुडे। ठीक है, देखो स्टुअर्ट ट्रैविस सिंड्रोम इन ब्रेस्ट विल हैव modified radical mastectomy history, 5 to 10 years of gap. There will be bluish discoloration with the limb swollen. Bluish discoloration is a very, very important pickup point to look for Stewart-Travis syndrome and the period between MRM and the lymphedema. Okay. All right. So you guys have been amazing. Absolute amazing. I can't even complain about it. I mean, whatever I asked you, you did. 1 second. Chat box not chalaga. Take second, guys. I'm not able to see what you're saying. Okay. Right. So thank you so much, guys. I mean, yeah. Thank you guys. Thank you. Right. Try to revise as much as possible. If you have any questions, any queries, you can reach back to us. I will upload the set of PDF. I'm doing it right now. I will export this completely into our Telegram. Thank you, Roy. Thank you so much, guys. Thank you so much. I mean, you guys have been absolutely amazing. Great. Yeah, any questions, any queries, feel free to reach out anytime. It is sufficient for your FMG exam. Revise. जितना मैंने आज पढ़ाया है इसको वापस रिवाइज करो, 10 बार रिवाइज करो. It is easy, you will finish it in no time. I'm going to share it across. ठीक है, make sure you revise it and forget about surgery. Surgery में इतना ही है, इसके beyond नहीं आएगा. That's the belief system that we are going to put. अगर आएगा तो सबके लिए बाउंसर है, उसके लिए टेंशन ही नहीं लेने का. वो 10% चीज के लिए अपनी बाकी टाइम अपना खराब नहीं करेंगे. वी विल नॉट कॉन्सेंट्रेट एनीथिंग बियॉन्ड व्हाट इज टॉट टुडे. जितना मैंने आपको आज पढ़ाया है यही आपके लिए, आई विल से दिस इज द होली ग्रेल ऑफ सर्जरी दैट यू नीड टू रीड. दैट्स इट, नथिंग मोर देन दैट. With that, thank you so much. You guys have been amazing. I would love to interact more, but I know it's late. 12 बज रहे हैं, so I don't want you to have overburden. Go sleep on it. Tomorrow come back and revise it. Okay? Any questions, any queries, do tell me as soon as possible. NEET PG ka marathon is going to start soon after the FMG ends. We will have even more intense session for that. Thank you so much, guys. Love you all. Good night, and thank you for being patient with me. Bye bye.